bronchi. And usually it is associated with the clinical syndrome of cough, sputum production, and recurrent chest infection. Now, the prevalence really, or reporting the prevalence, is really different from one society to another. I think it's because of the long period of neglect and as well as the awareness and the prevalence. It's really different heterogeneous disease with many causes, associations, many clinical radiological features, as well as their presentation, their natural history is different. So I'm mentioning here the non-cystic fibrosis bronchiectasis. It's absolutely different from the cystic fibrosis nature. Now, the pathophysiology behind bronchiectasis, our understanding, it's coming back to 1986 with the Collie vicious cycle of understanding the pathophysiology. So the key component of the disease, we have chronic inflammation leading to impaired mucociliary clearance, a more chronic bacterial bronchial infection, and at the end, we have structural lung damage, and the fishes will go along. The common infections, we have Haemophilus influenza, we have Pseudomonas infection, predispose them to have more neutrophilic infection, more cytokine release, as well as interleukin-8, leading to more kind of chronic infection. And the evidence base behind it is really the Pseudomonas infection, leading to threefold increase in mortality, as well as sevenfold increasing in the hospitalization. Now, I will go through the new update, let's say, or some updating statements in the non-cystic fibrosis bronchiectasis according to two main guidelines, ERS and the PTS, updated in 2019. The first part of that is really the diagnosis. Keep in mind, we have a minimum bundle of etiological testing to be done in any patient with newly diagnosed bronchiectasis. That includes differential blood count, looking at the lymphocyte, neutrophil. Some patients are neutropenic, lymphopenic, maybe underlying malignancy. Immunoglobulins, very important in any patient with bronchiectasis, looking at immunodeficient. ABBA, allergic pulmonary aspergillosis, part of the International of a Human Mycology Society. We should test IgE, specific IgE, allergic to Aspergillus fumigatus, IgG level, as well as the eosinophil count. And then, according to the patient phenotype, then you can add additional testing. Please do not forget the microbiology is the very important part in the bronchiectasis, so sputum culture important at baseline, and then follow-up patient is also important, looking at the ANTM infection. HRCT considered to be the standard for establishing the diagnosis of bronchiectasis. Please do not forget, we have other causes, other phenotypes. So extend your investigations according to the patient. So for example, we'll go through one phenotype. First patient, he's a 42-year-old man. He works as a gardener. He got really difficulty to maintain his business because of recurrent chest infection. He tend to have a cough. So he's a daily cougher with more of chest infection per year. He struggled to gain weight. He's married without children. His baseline sputum is Pseudomonas aeruginosa. Looking at the CT, you can notice variety or varicose and cystic bronchiectasis, mainly in the upper lobes. So with this type of phenotype, so family history as well was positive. His history of infertility, severity of disease, young age, upper lobe predominant bronchiectasis. So this phenotype will be pushing toward genetic, maybe cause could be cystic fibrosis. So his genotype for cystic fibrosis was positive for heterozygous 508 delta R117H with positive sweat chloride. So this is the first phenotype of the PTS-ETS statement for the CFTR mutation to be tested in this kind of patient. Second phenotype, 45 years old, he's an artist, asthmatic since childhood, but it was pretty controlled, and now we are dealing with uncontrolled symptoms since a year, frequent exacerbation, frequent hospitalization, not responding to usual antibiotic steroid. He got more new symptoms of sputum. So his CT showed central tubular bronchiectasis. In this stage with asthma background, he got phenotype of high eosinophil, and his IgE is more than 2,000. He's allergic to aspergillus. So maybe we are talking about here the ABBA part of the phenotype. Phenotype 3, he's also a young student from Pakistan. He got really recurrent chest infection, but the main history, he got recurrent ear infection and sinus infection leading to partial hearing loss. His brother also got the same symptoms. It's very interesting to have a look to the X-ray. He got dextrocardia, and the CT showed bronchiectasis mainly localized in the lingula. Interestingly, this patient got a very significantly low exhaled nitric oxide, which is considered to be one of the pathogenomic in patients with PCD. So he got electron microscopy positive and genetic also for outer dynan artifact defect, as well as he's positive for DHAH5, which is the common genetic disorder in PCD. So this is the type of phenotype in this patient. Now, going to an older patient, 77-year-old retired librarian. He got a chronic cough, but he got fatigue, weight loss, fever. He's been positive for AFB, but the culture code also showed Mycobacterium avium complex. So we are dealing here with a Mycobacterium, either non-tuberculous or tuberculous post-infection bronchiectasis. So these are kind of a brief, but keep in mind, we have other kind of phenotypes. Do not forget the common ones, COPD overlap with bronchiectasis. We have alpha antitrypsin deficiency. We have systemic inflammatory disease like rheumatoid arthritis patients, as well as inflammatory bowel disease like ulcerative colitis. Now, what about exacerbation or part of treatment? I need to admit that most of our guidelines from non-cystic fibrosis coming from the CF population with the antibiotic duration is the same. So the main consensus about the use of antibiotic duration is really 14 days duration. I can say it's really based on the expert consensus and studies that don't documented a good outcome for this patient. But again, the task force also panel suggests mild exacerbation with more sensitive antibiotic like Streptococcus pneumoniae. Still, we can consider them for oral antibiotic, but again, the evidence for is really lacking supporting the short course treatment. One of the main study here, published in ARJ, study 32 exacerbation patients, 14 days showed improvement in 24 sputum volume, bacterial clearance, CRP, and then also a respiratory questionnaire, but there's no improvement in the PTS published also several antibiotic guidelines for first line, second line for most of the common organisms, including also Pseudomonas aeruginosa. What about the eradication? Yes, eradication is important, but specifically and evidence-based mainly in Pseudomonas patients. And that's only for patients with first isolation, or you are regrowing in the context of intermittently positive cultures. Those patients will benefit from the eradication. And we are aiming to achieve complete or clearance of the pathogen from the airway. Why is that? Because they do have more exacerbations and poorer quality of life. Now, sometimes it will be really difficult to know it is an acute Pseudomonas or it's a chronic Pseudomonas, and this is first time for you to see this patient. Yes, that's true. So the definition of a chronic infection cells will be defined as two or more isolate of the same organism. If you have it at least 3 months in a 1 year, that's considered to be chronic infection. So patients will really not be fully eradicated, or the failure rate will be high. Now, what will be the first line? So concentrating on the Pseudomonas, first line, oral, ciprofloxacin for 2 weeks. Second line will be IV. Now, comparing oral IV, yes, there is one study published recently, but mainly for pediatric cystic fibrosis. There is no big difference between them, but I can say a lot of side effects with IV. So oral is preferable first line. And then followed by your oral, the 3 months of inhaled antibiotic, either colistin, gentamicin, or topramycin, preferably the colistin or the colomycin. Now, ERS published very nice kind of a simple pathway to follow for first isolate of Pseudomonas. The background or the base of it is really oral, followed by 3 months of inhaled antibiotic. Now, what about bronchodilators? Are they still important in bronchiectasis? Yes, mainly in patients with significant breathlessness, patients with obstructive pattern in pulmonary function test, patients will have some asthmatic component of it. What I'm including here in bronchodilators are either SABA and steroid. We all know inhaled corticosteroid not very evident in patients with pure bronchiectasis without airway. There are some publications about budesonide use or formoterol combined with budesonide. There's no really big data about it. But background of using bronchodilators and bronchiectasis is very important because it's part of the physiotherapy or chest clearance pathway. So my patients, I advise them to follow the line of either first a short-acting bronchodilator, then mucolytic. Patient will start to do airway clearance by any ways that we will explain in the next slide, followed by inhaled antibiotics. So the last line will be inhaled antibiotic, prepare them or prepare the airway once it's clear to have the antibiotic. The physiotherapy emphasizes about the importance of airway clearance and pulmonary rehab in patients with bronchiectasis. So aiming of what your patient is either mucus problem or exercise intolerance, or they do have respiratory weakness. So if you are considering about mucus problem, we have specific teaching by our physiotherapy as well as in our clinic using kind of active cycle breathing or postural drainage, as well as using PEP mask or flutter or a capella as an oscillatory PEP mask, followed by the exercise tolerance like aerobic or strength exercise. Usually we advise our patient once or twice a day until they can reach a clear huffs or coughs. And usually the minimum will be 10 minutes to 30 minutes. Now, what about outcomes? Are any data about outcomes for improving our stable patients' outcome? Yes. So we are talking here about the more evidence used in inhaled antibiotic and macrolide, so two arms. Inhaled colomycin, evidence-based and frequent exacerbator. Topramycin is the top one in EVOLVE trial with improvement in pulmonary function test. Inhaled estrogen, I can say it's the beauty about it is the e-flow. Within 5 minutes, patient can take the antibiotic, but it's mainly evident in cystic fibrosis population. Azithromycin, erythromycin, three nice randomized controlled trials, evidence-based and used in patients with frequent exacerbator. If you cannot use azithromycin or erythromycin, still you have other line like tetracycline. Now, cyclic intravenous antibiotic, it's kind of an old kind of a practice, but usually it's used in a very severe bronchiectasis, pre-transplant. They do have a lot of exacerbations per year, frequent severe hospitalizations. Now, frequent exacerbator plan, again, ERS, very nice algorithm. We have Pseudomonas patient, non-Pseudomonas, so depends on your patient microbiology. Pseudomonas patient, please prefer the inhaled antibiotic. And then second line will be the macrolide, and the opposite to the non-Pseudomonas. First line is macrolide, followed by inhaled antibiotic. So 3 randomized controlled trial, inverse path plus about the macrolide, azithromycin, erythromycin. The doses will be really depending on your patient tolerance. Usually advised to start 250 azithromycin daily or 3 times per week, and then you can modify accordingly. Now, why we are mentioning about inhaled antibiotic? Because they have a very low kind of molecular mass, 1 to 6 micrometer, can really deposit early to the alveoli, to the airway, indifferent to the IV or oral. Keep in mind, yes, they are available, but choose your patient correct. Adverse event or adverse side effect from azithromycin, I can say it's dose related. So 250 twice weekly, it is considered to be a good starting dose, and then you can change accordingly. Now, even our threshold to consider those patients for long-term treatment, like with antibiotic, either inhaled antibiotic, sometimes we can lower it. It's really dependent on your patient nature. Sometimes they do have very severe exacerbation, very poorly responding to treatment, or they are immunocompromised, needing a lot of IVGs or oncology patient. The long-term antibiotic, again, it's kind of a complex. It will really depend on the patient tolerance, allergies, sensitivities. Challenge test before starting inhaler antibiotic, it's important. I know maybe the practice changed from one facility to another, but challenging or doing a kind of a challenge test before antibiotic is important to make sure they cannot drop their pulmonary function test or they do have some spasm post-inhaled antibiotic. I have one more slide, I think. What was? Yeah, the last slide, it's not in the presentation. I think this version is not the correct one, is about looking forward to the bronchiectasis for years later. Are we handling a new generation of a treatment? The answer is yes. Consecutive, one of the neutrophil elastase inhibitor, it's published as phase 2 trial. It's an oral treatment, can be used or studied in non-cystic fibrosis patients. We have inhaled ciprofloxacin, it's in the way, as well as other kind of COX receptor antagonist, also an oral neutrophil elastase medication. It's in the studies. So by this, I will end my presentation and happy to take any questions.
Thank you very much, Dr. Amel. It was an outstanding presentation. You have made lots of information in a very concise, timely manner presentation. So I congratulate you for that. It's a hot topic, and it's probably those kinds of patients that we come across in our daily encounter in clinics and hospital rounds. So the floor is open for questions. Yes, sir.
Preparation here, or what dosage for amikacin nebulizer?
Yes. So amikacin usually, I mean, the main studies about use of amikacin was for the NTM infection, part of protocol like for Mycobacterium abscess. This is my practice mainly. In our hospital, it's the main use as well. It's not that very much really in the publication of non-cystic fibrosis patients, so it's not that very much really used. It has its own side effects. It has its own way of administration. We have a new way of using amikacin, not by nebulizer machines. So we have another new in the coming, using like similar to the estrogen, where the A-flow, we can use it in 5 minutes. So it has its own way. The summary, yes, it's used, but it's mainly in the NTM patients.
I have a question for you, Dr. Amel. It's very often that we come across patients who frequently grow organisms in their sputum without necessarily having an overt symptom. So how you would deal with those?
That's an interesting question. I think it's a challenging sometimes, especially because the data is really mainly in cystic fibrosis. In cystic fibrosis, so the one is important. MRSA should be eradicated as well, part of their regime. I can say the non-cystic fibrosis patient is really limited data. The answer will be guided by the patient. So guided patient, radiologically, how they are doing pulmonary function tests, any progression of their disease in cystic fibrosis, and the bronchiectasis, the answer will be yes, they consider to be treated. But eradication, there is no really big evidence rather than Pseudomonas aeruginosa.
I can see the question.
Excellent presentation. Thank you. Noman Chaudhry from Mubadala Health. Because of the presence of non-tuberculous mycobacterium in some of these patients, if you're going to start these patients on long-term azithromycin, would you do a bronchoalveolar lavage, the bronchoscopy beforehand?
So the two points to raise with this, thank you for the question, is first, using macrolide in patients with non-cystic fibrosis or cystic fibrosis. First, we need to do sputum culture for the NTM. I think that's a little bit sometimes we are missing in our practice, but it's very important because that can reflect the risk to have NTM later or resistant later. The second point, do we need in all patients to do bronchoscopy before starting NTM? The answer is no. If you have a good culture amount or the microbiology is happy to grow the NTM, it's enough without going to bronchoalveolar lavage. I mean, the third part of answer is the sensitivity to the to azithromycin or azithromycin according to the NTM lab that you have. It's part of the also practice.
Question, I also throw one question through. One of your slides, you have shown the cyclic parenteral antibiotics.
Yes.
Is that replacing the rotating antibiotics?
Yes.
The oral rotating antibiotics?
Yes. So those really patients that I face, they are really severe bronchiectasis. Pre-transplant, they are in the transplant list, or patient really immunocompromised with like deficiency, immunoglobulin deficiency, or on active chemotherapy. They do really have severe exacerbation. They will be really sick during the hospitalization. Yes, cyclic antibiotic IV.
Thank you very much, Dr. Amel, for your interesting presentation.
Thank you very much.